In this video, we're going to be looking at the wrist and hand. So first off, to review the bones of the hand here, we can see the scaphoid, which remember is going to articulate with the radius, the distal radius, the lunate located just lateral to that, which is also going to be articulating with the radius as well as the ulna, the triquetrum, and then the pisiform, which is located anterior to the triquetrum. Then we have coming back around to the medial or the lateral aspect of the hand, we can see the trapezium, which remember trapezium is next to the thumb. So the metacarpal of the thumb is approximated, or it's going to form a joint with the trapezium. Next to that is the trapezoid, which is going to articulate with the second metacarpal. Capitate, which is the large central bone in the distal row of carpal bones. And then the hamate, along with, remember that's got the hook of the hamate on it as well. That's going to articulate with the fourth and fifth metacarpals. Now we have a dorsal view, looking at these bones again. So here we can see scaphoid, lunate, triquetrum. Remember, you're not going to be able to see pisiform from this view. Trapezium, trapezoid, capitate, and then hamate most medially. Here we have a plain film radiograph of the hand, so we can look at the carpal bones quite readily in this image. So we can see the scaphoid, lunate, triquetrum, and then you can make out the pisiform there as well. The trapezium, again sitting right there at the base of the first metacarpal. The trapezoid bone, which you can see how the trapezium and the trapezoid sort of overlap each other, so that can make it a little bit difficult to tell exactly where the margin of those two bones is. Then we can see the capitate, and finally the hamate. So you'll note with the scaphoid that there's actually something known as a scaphoid view, and that's because with a direct AP view, that's going to cause the distal pole of the scaphoid to be, it can be difficult to appreciate that distal pole of the scaphoid. You'll be able to see the mid-body, but usually the distal pole or the waist of the scaphoid, but the distal pole can be difficult to appreciate. And so what we oftentimes will do is, if we have a suspicion of a scaphoid injury or fracture, we'll have the patient move the wrist into an ulnar deviated position, or basically an adducted position. And when they do that, that allows us to be able to better appreciate the entirety of the scaphoid bone, including both the distal pole, the distal and proximal poles, as well as the waist coming across the middle. So here we have an example of a minor scaphoid fracture, so you can make that out quite well in this radiograph. And then this is evidence of osteonecrosis of the scaphoid bone, and this is relatively common, partially because it can be difficult to identify a scaphoid fracture on conventional imaging, and so when it's missed, it can lead to necrosis of the bone due to disruption of the blood supply to the bone in the case of a fracture like this, and so that leads to this necrotic situation where the bone will actually start necrosing, and so that obviously makes it a much more challenging situation to address in that patient. This is an MRI view of the wrist joint. So one thing to note here is there's space in between the scaphoid, which you can see here, and the lunate bone, which you can see right here. And so the space between those two is called the scapholunate space, which is typically relatively small. It's usually less than 3 millimeters, but in some cases you'll see that gap will widen, and that might indicate a rupture of the scapholunate ligament. And we call that the Terry Thomas sign, which for those of you, like when I first heard that, I had no idea who Terry Thomas was. He's a famous comedian who had a gap in between his front two teeth. So for younger radiologists now, oftentimes they refer to this as the David Letterman sign, because again, he's got the gap between his front two teeth. And so again, when that scapholunate space widens, that's going to be what indicates a likely rupture of the scapholunate ligament, which again is not present in that patient. In this image, this is sort of an interesting view of an MRI of the radiocarpal joint, which you can appreciate quite well with the scaphoid and the lunate. But then over here, you'll note that there's an abnormality here of the triangular fibrocartilage complex. And so this is a series of ligaments as well as some fibrocartilage that's located in between the lunate triquetrum and then the ulna, and then the sort of the medial part of the radius. And so any sort of disruption or injury to this triangular fibrocartilage complex is going to be able to be fairly well appreciated on an MRI view, as you can see in this case. So here we have an X-ray. So this is a conventional radiograph of the hand. And so just to review some of the bones that you can see there, so we can see the distal, middle, and proximal phalanges. And then remember in the thumb, you only have two. You have a distal and a proximal phalanx, which is going to be just distal to the first metacarpal. And then here with a lateral view, you can appreciate these various bones in view, with the distal radius being easily viewable from the thumb side. And then in this image, you can see the ulna on the pinky side. So this is going to be basically a medial view. This is going to be effectively a lateral view here on the left. And so I'm just going to go back here real quick to this image. So here you can see the first metacarpal, second, third, fourth, and fifth, and then proximal and distal phalanx, proximal, middle, and distal phalanx on each one of the digits. All right, and then in addition to the bones, we also have a number of joints, obviously, in the hand. So the metacarpal phalangeal joints, you can see clearly right here. And this is an adult. You don't see any of the epiphyseal plates. And then you also have the proximal and distal interphalangeal joints that you want to make sure to look at when you evaluate in a radiograph of the hand. And then with the metacarpals, remember that there's three major components to each metacarpal. We have a base, which is proximal, shaft, and then the distal head of each one of them. And so again, you want to have a systematic approach to evaluating each of the bones and joints of the hand. And then also you don't want to forget to evaluate the proximal aspect of the wrist. But the good thing is, typically when somebody comes in complaining of some sort of issue with their hand, they have a pretty good sense of where the pain is located, and so you can direct your attention just to that location. So it's more challenging when you're looking at a plain radiograph and you don't know anything about the patient or their relevant history. So this is just a good review of the various bones of the hand and the wrist. So I would recommend that you take a little bit of time to look through this and make sure that you're able to identify all the different bones that are shown on here. So again, you can see the proximal and distal row of carpal bones, the metacarpals, and then all of the phalanges are all labeled. So take a moment and look at the yellow arrow in this radiograph and think for a moment if you can come up with what that structure is. So it turns out that this is a totally normal occurrence. This is a sesamoid bone situated right at the base of the thumb, at the head of the first metacarpal. This is an example of a boxer's fracture. So this is the fifth metacarpal that's been affected. So you can see where it's been fractured. And so if you think about the name behind this, when somebody punches another person and so they've made a fist, the primary point of impact is going to be on the heads of the metacarpals. And so the weakest of the metacarpals is going to be the fifth metacarpal. And so that's very commonly fractured in people and somebody that punches another person. And so that's why we call this a boxer fracture. This is called a mallet finger or deformity, or a baseball finger. So this occurs from hyperextension of the finger, and so this is where the extensor digitorum, you can see where it attaches at the base of the distal phalanx, and so that can cause a fracture of the base of of that distal phalanx, and so we call that a mallet or baseball finger. So take a moment and look at this image, see if you can identify the abnormality or the deformity. So if you once again draw your attention to the fifth metacarpal, you can once again see evidence of a boxer fracture in this individual. And then this is just another view of the same patient, where you can appreciate the boxer fracture in this person. All right, so this one shows a relatively obvious deformity, once again in the fifth metacarpal. So you can see here where there's approximately a mid-shaft fracture of the fifth metacarpal. All right, and so if you look at this image, take a moment and see if you can find any abnormalities. So I would assume that you would not be able to see any abnormality in this image. I certainly don't see one, but if you look at an oblique view in the same patient, you'll notice that now you can appreciate a fracture of the fourth metacarpal in this patient. So again, this comes back to the idea that one view is no view in radiology. So you always want to make sure that you look at two different views, because if you go back an image, I mean, you don't see, I mean, it looks a little skinnier perhaps than the others, but you don't see any obvious evidence of a fracture. So once you look on that oblique view, now you can see a very clear and obvious evidence of a fracture in this individual. So now here we have another plain film. So this is going to be the initial film that was taken in this individual. And again, I think if you look closely, you probably won't see any obvious evidence of any abnormality in this patient. But then on follow-up, this patient who had significant wrist pain, you'll note that they had, this was 8 days after the initial visit, you can see where they did a repeat scan, and now you're able to see a very obvious scaphoid fracture. And so that's common, where over time, fractures oftentimes within the first week or so become more evident over time. And so again, we can see here that this person has a clear scaphoid fracture. And so again, repeat imaging is mandatory when there's a high clinical suspicion of a scaphoid fracture if it's not initially detected, because that does commonly occur. And here you can see the treatment of the patient where there's a non-union fracture of the scaphoid bone. And so in this case, a bridging screw was placed in order to bridge the two fractured components of the scaphoid. And finally, here we have a dislocation of the fourth digit. So you can see the proximal interphalangeal joint has been affected in this patient. So again, you can see here on the oblique view where it's very obvious. From this AP view, it's a little bit harder to tell that it's been dislocated, but when you look at this lateral view or oblique view, you can see very clearly that it's very significantly dislocated in this individual. And so that concludes this lecture.